Hi guys, good evening. Can you all see me? Can you all hear me? Quick feedback. Hi guys, good evening, good evening. I hope everybody is able to see me. Hi, good evening guys. Right, so we'll pick up from where we left off yesterday. So what did we discuss yesterday? We spoke about the benign disorders, right? So in the same context, we'll continue in the same series. So today we'll add few more topics, but then we'll start with today with a very common disorder that you will see in the patients who come to your OPD is what we call it as breast pain, and that is your mastalgia. This is called as mastalgia, right? So the word mastalgia basically it refers to as breast pain. It is mastodynia also. So there's other synonyms that we usually use it, but mastalgia is what we are going to address, and this is the patient is going to present as breast pain. Now there are various reasons why a patient can develop a breast pain. So I'm going to categorize the mastalgia based upon its presentation into two basic categories. We have cyclical and the non-cyclical mastalgias, right? So we divide the mastalgias into two components. One is your cyclical mastalgia. One is the cyclical mastalgia, another one is non-cyclical mastalgia. Non-cyclical mastalgia, right? So we divide them into two categories. One is cyclical mastalgia, another one is non-cyclical mastalgia. What do you mean by this? Now, as we all know, the word mastalgia is nothing but breast pain, right? So when I say the patient is having a cyclical mastalgia, that means this breast pain will be cyclical. So what do you mean by cyclical? That means it will come repeatedly again and again. So when will it come? So it will coincide with menstrual cycle, right? So breast pain associated with menstrual cycle is what we call it as cyclical mastalgia, right? Now those breast pain which does not have anything to do with the menstrual cycle, that means it's constantly present, it does not vary with the time or it does not vary with menstrual cycle, such cases is what we call it as the non-cyclical mastalgias, right? So the non-cyclical mastalgias are breast pain irrespective of menstrual cycle. It is breast pain irrespective of menstrual cycle. So the breast pain irrespective of menstrual cycle, and that is going to be your non-cyclical mastalgia, right? Now, when you talk about how do you compare? So both, obviously, when the patient comes down to you in the OPD, the principal complaint would be breast pain, breast pain, breast pain. Yes, there is breast pain, right? But then how do you know that probably it is cyclical, other is non-cyclical? One of the greatest component will be, yes, the pain will coincide with menstrual cycle. So I know it is cyclical mastalgias, and those who do not coincide, that is irrespective of menstrual cycle, if the component of pain persists, we call it as non-cyclical mastalgia, right? So hi, Nicole. Right, so, but then apart from that, how else can you differentiate this, right? So the first, it is going to be the age at which you're going to see. Cyclical mastalgias, when you see, they're usually seen in the third decade of life, whereas non-cyclical mastalgias are usually seen in age above 40 years, right? So the first cue point is going to be age. You see, cyclical mastalgias are seen in third decade, non-cyclical are usually seen after the fourth decade of life, right? Now, when you look at the involved sites, or we call it as the laterality, that is going to be unilateral or bilateral. Cyclical mastalgias are usually bilateral. Non-cyclical are usually unilateral, so they are specific to the sites of the pathology. I'm not saying they cannot be bilateral, but most often they present to you as unilateral. Most often they present to you as unilateral pain, right? So age is the first determinant factor, then is the laterality is the second determinant factor, then you will see the area which is going to be involved. So when you say the area involved, you will notice when a patient with a cyclical mastalgia comes, no, she will not tell you that it hurts at a specific location. In fact, she'll take the entire hand and she'll say this entire area hurts, right? So I say the cyclical mastalgias are usually diffuse in nature, whereas non-cyclical are usually localized in nature. They're usually localized in nature. Okay? Nikhil, this is not an obs and gynae class. Episiotomy, if you want to learn, you have to attend your OBGY lectures. It's a simple context of episiotomy where you're opening or you're extending the vaginal orifice so that the delivery becomes quite easy. It's usually into the lateral perineal wall that you extend the incision into. If you want greater details of episiotomy, you have to consult your gynecologist or your obs and gynae faculty. Okay? Chalo. Now, when you say what are the causes? When you say the causes for cyclical mastalgia, these are usually non-specific. In fact, many a times, we have seen cyclical mastalgias usually revert with respect to, when I say reassurance, or usually when you rule out malignancy and tell the patient, okay, there's no cancer at all, they usually settle off. Okay? So we usually say the non-cyclical mastalgias are usually non-specific. It is the cyclical mastalgias that are cause specific, and two major causes that I would like to discuss here. Number one, it is going to be your Tate's disease, and number two, it is going to be your Mondor's disease. So number one, it is going to be the Tate's disease, and number two, it is going to be the Mondor's disease. One, it is going to be the Tate's. Another one, it is going to be the Mondor's disease, right? So what is a Tate's disease? Now, Tate's disease is nothing but it is the patient will have mastalgia or the pain will be present, usually unilateral. But here you will see it is because of costochondritis. It is usually because of costochondritis, right? So what is this costochondritis? Costo means ribs, chondro means cartilage, itis means inflammation. So it is the inflammation of the cartilaginous part of the ribs, which are usually onto the medial side. So patient says it hurts here, right? So because the patient cannot perceive it as a rib pain, the patient thinks because it is arising from the area of breast, she misperceives this as mastalgia. So there is a costochondritis. Now, if they ask you what is the usual rib, the most common rib involved, it is going to be the second rib. The most common rib involved, it is going to be second rib, and there will be a persistent dull aching pain. There will be a persistent dull aching pain, and this is what you have a patient of Tate's disease, right? Now, when you say the Mondor's disease, Mondor's is because of non-migratory superficial thrombophlebitis. It is non-migratory superficial thrombophlebitis. So as you can see the name itself, non-migratory means it is constant or seen in one particular location. Superficial thrombophlebitis, that is superficial vein inflammation. So inflammation of the superficial veins is seen on the breast surface, and this is what we called as the Mondor's disease. Now, because it is going to occur repeatedly, and recurrent inflammation anywhere in the body heals by fibrosis, and whichever vein it is going to inflame, that vein is going to get fibrosed and become a band or a cord-like structure. So the characteristic feature of the Mondor's disease. The characteristic feature of the Mondor's disease will be presence of band or cord-like structures. There will be band or cord-like structure. Now this band or cord-like structure, which is seen in the Mondor's disease, they are usually seen in the inframammary region. They are usually seen on the inframammary region. So it's a non-migratory superficial thrombophlebitis. It is usually associated with a band-like or a cord-like structure because of the fibrosis of the vein. And if you ask you what is the most common vein involved, the most common vein that is going to be involved here is going to be the lateral thoracic vein. The most common vein that is going to be involved, it is going to be the lateral thoracic vein, right? So these are the two major reasons why a patient is going to present to you with a non-cyclical mastalgias, right? So cyclical mastalgias are those mastalgias which are going to be associated with the menstrual cycle, and non-cyclical mastalgias are those mastalgias which are independent of the menstrual cycle. This is the basic concept, and this is how a patient is going to present to us if a patient has mastalgia. So if a patient has mastalgia, this is how the presentation of the patient would be like, right? Majority of the times it is actually a diagnosis of exclusion that you will go across. So let's say you have a patient of mastalgia, right? So how would you like to manage? So when we say the management of the mastalgias, no, it is quite easy and important. But before that, there is a small table that I would like to share you. It is called as the daily breast pain chart. This is followed across all the breast surgical OPDs that we run. This is given to the patient who experiences mastalgia. Okay? Any patient who comes with mastalgia into the OPD, we will give this small chart and we'll ask the patient to bring this chart every time the patient comes to you in the OPD. Now, this breast pain chart is actually originally given by the Cardiff, right? They're originally given by the Cardiff, but this is what we're talking about, the modification of the Cardiff chart, which is modified by our All India Institute of Medical Sciences. That is a AIMS modified Cardiff chart. Okay? So what is this chart? It is an AIMS modified. So I don't want you to overcook this. This is an AIMS, sorry, if you want me to write it, I will write it. This is what we call it as the All India Institute of Medical Sciences, our proud AIMS modified. It is AIMS modified Cardiff breast pain chart. Cardiff breast pain chart, right? So this is a chart that we are going to give to the patient. So what do you have? You have the name of the patient. You will write the age of the patient, and obviously a hospital unique identity number or whatever you have. All that will be put in this particular chart. Now the first date of the visit and the month of the visit, you have to mark it in this chart. Now duration of the complaint, you will see, we'll write it only for the first visit. Whether it is the right breast or whether it is the left breast, you will mention it on the first one. Okay? Now then you'll see we have something called as the pain analog system, which is called as VAS system, that is visual acuity pain management. Okay? So whatever pain that you have, we measure on a score of 0 to 10, which is called as the VAS scoring pattern. So 0 means absolutely happy, no pain, and 10 is unbearable, and the patient looks like this. Okay? So we'll ask the patient to say 0 is no pain, 10 is unbearable pain. You rate your pain, because pain is always specific to the patient who's experiencing it. It cannot be quantified, but yes, you can always have a set pattern which is set to your own liking, right? That means you might have a higher threshold of pain. So let's say for me, which is 8, for you it might be 6. But it can't be 0 to you, right? So that means some amount of pain is experienced, and we'll see whether the pain is improving or deteriorating. So we will see that the breast pain score on all the days. So you have to mark. So on the first day, what is the score like? So let's say on the first day, patient says score of 4. Then it is a score of 5. Then it is score of 4. Then a score of 5. Then a score of 6. Then a score of 5. Then a score of 4. So you will continue to mark out the entire month of the both right and the left breast. And then the patient is going to come down to the OPD. Then you will see the monthly periods also, right? So in the period score, you will see that on the day of the menstrual cycle, whether the component of pain is increasing or remains same or does not exist. So that is how you know whether it's a cyclical or a non-cyclical mastalgia. So this is what we call it as the AIMS modified, that is All India Institute of Medical Sciences modified Cardiff breast pain chart. From our exam perspective, what are the components they'll ask you? They will ask you what are the components that you will include. See, this basic data will be included. Only the first visit you will see duration of the right breast or the left breast pain. Then you have the VAS score. So what are the components that you have? You have the VAS scoring, that is your visual assessment of the pain score, or visual pain score, what we call it as. Now this VAS score will have 0 to 10, 0 no pain, 10 extremely painful. You will score each individual breast pain, that is the right breast, left pain, and then you'll also see which days are your menstrual cycle, and during those days whether the common of pain is increasing, decreasing, remain same, and then you will be able to come to a conclusion whether it is a cyclical or a non-cyclical pain. Okay? So this is the activity that you do. Now let's say you have a patient. Let's say you have a patient who has presented to you with breast pain. So how do you manage your patients of breast pain? So treatment of breast pain in an algorithmical manner. Now, this is something which is going to be important for every single one of you who are going to sit in an OPD, especially if you're a resident. This is something that is expected for you to know, right? So the treatment of breast pain. Treatment for breast pain. See, in the Bailey, there is another component that is given, which is also called as the Cardiff-Lucknow nodularity scale, where you have 0 means no nodularity in the breast, and then you have a 4 means extremely high nodularity, but that is just to give you a visual component, nothing important about it. Okay? So how would you like to treat a patient who has landed up in your OPD with the breast pain? So it's a sequence, so you will follow a structured component, right? So what is step number 1? The step number 1, it is to exclude breast cancer. It is to exclude breast cancer, or I can say rule out breast cancer, and then move to step number 2. The step number 2, once you have ruled out the breast cancer, most of them, they do well when you say there's no cancer, nothing is found, and you reassure the patient. The step 2 is to reassure the patient, right? Now, after reassurance, if the patient feels that it is not helping, the step 3 is to start the treatment. Now, the first thing that you will do is always, because see, sometimes the pain in the breast is also because of the heavy, sagging, soggy breast, which is going to cause that, discomfort. That sagging discomfort, or the weight of the breast itself causes pain. So the first thing, it is going to have a tight supportive brassiere that is going to be giving adequate support. So it is an adequate breast support. To give a patient an adequate breast support. So exclude the cancer, reassure the patient, and then give an adequate breast support. Usually we say it's a sports brassiere that helps to hold it firm. Okay? Now, if these fail, so this is the first set which is failed. If it fails to provide any result, then you move to the next phase, and this is medication, right? So this is your, I would say, phase 1. Now, if this does not work out, now I'm going to phase 2. And the phase 2 here is going to be medication. I'm going to start the patient on medication. So initially, the medication that we are going to consider, or we are going to start in this patient, number 1, we'll start flax seeds. So you can give a flaxseed extract or flaxseed, which is going to be a flaxseed oil basically. It is going to be 30 grams daily. Or you can say flax seeds directly. You give 30 grams on a daily basis, or a topical application of the primrose oil. A primrose oil topical application. You ask the patient to apply it locally. So flax seeds, which is going to be 30 grams on a daily basis, right? Or a evening primrose oil, that is going to be an oil extract which you ask the patient to apply on a daily basis. Okay? Now, if this does not work, then you can give analgesia, that is your topical NSAIDs, that is a non-steroidal anti-inflammatory drugs. Usually it works for mild to moderate breast pains, right? Now, if this does not help, if this fails, then you enter the phase 3. The phase 3 is step up medication. It is going to be step up medication. You take the patient for the step up medication. So in a step up medication, what are we going to consider? So in a step up medication, remember here, if the visual score, the VAS score is more than 3, after going through the medication phase, you have started the patient on medication, but the VAS score is persistently more than 3, then you would consider for the step up medication. So here you can give tamoxifen. Tamoxifen is given 10 milligrams daily. I hope everybody knows tamoxifen is a selective estrogen receptor modulator. So this is a drug that can be prescribed as 10 milligrams on a daily basis. You can also prescribe danzol. You can also prescribe danzol, which is going to be 50 to 300 milligrams on a daily basis. On a daily basis. If it does not work, you can also go with LH-RH agonist. But this is going to be only for short duration, right? So tamoxifen can be given for 3 to 6 months. Danzol can be given for 3 to 6 months. LH-RH agonist we usually prescribe for 1 month or 1 to 3 months. That is under 3 months only, right? If you're considering for long-term medication, then it is to be tamoxifen or danzol, or LH-RH agonist if you're considering for short-term medication. Okay? So, any patient who comes to you with breast pain, how do you consider the management protocol? The management protocol is quite simple. So, guys, today's topic is very, very important because this is what you're going to encounter very often in your OPD as well as in your clinical postings. When a patient comes to you with breast pain. If a patient comes to you with breast pain, the step number 1 is to see whether it is a cyclical or a non-cyclical mastalgia. Cyclical mastalgia basically means the pain that coexists with the menstrual cycle. Non-cyclical mastalgia is a pain that does not coexist with the menstrual cycle. It is independent of menstrual cycle. I've given you how to differentiate between cyclical and non-cyclical. 2 best examples of the non-cyclical mastalgias are Tate's and the Mondo's disease. Now, any patient who comes to you with any form of mastalgia, you will give an Ames modified Cardiff breast pain chart so that the patient can assess. These are the components that you have to remember. What do you have? The basic information of the patient. The second thing you will have, the first visit, you will see the duration of the breast pain on the right and the left for the amount of time the patient is experiencing. Then you have the VAS score where the patient knows how to chart it. Then you have each right breast and left breast independent 30-day charting is there. And then you have monthly period charting. And then you will correlate the pain number, that is VAS number on that day of the month with the menstrual cycle. Does it coincide? And if the number is increasing, it becomes cyclical mastalgia. If the number remains unchanged, it remains non-cyclical mastalgia. And once you have a patient with a determined cause of mastalgia, this is the protocol that we follow. The first step, rule out malignancy. Second, reassure. Third, give a tight support to the breast so that the weight or that, the dragging component which is causing the stress or the pain reduces off. If that fails, then you switch to medication. Initially, it is going to be flaxseed 30 grams a day. You can give primrose oil, which is going to be applied topically, or you can give topical NSAIDs. If that does not work, then you have a step-up medication. The criteria for step-up medication, if you have the VAS score of more than 3, then you'll consider for tamoxifen, danzol, and LH-RH agonist. Remember, tamoxifen, danzol can be given up till 6 months. LH-RH agonist should be given only for 1 to 3 months of period. So, the short duration support that you give. Clear? So, this is with respect to mastalgias. Okay? Now, one of the major reasons of the mastalgia that you will see in your OPD is going to be breast abscess. So, I'm going to talk about a very, very important topic. It is going to be the breast abscess. So, when I say breast abscess, the breast abscess is also referred to as lactational mastitis. This is also referred to as the lactational mastitis, right? So why it is called as lactational mastitis? Because usually it occurs during the lactation phase. Okay? Now, when you talk about the patient who is having a breast abscess, number 1, if you look at what is the most important risk factor, the most important risk factor for development of the breast abscess is lactation itself, right? So, in that, what is the most common source? So, where do you get the source of infection? The source of infection is going to be the oral cavity. It is the oral cavity of the feeding baby. Now, to be very precise, it is not the oral cavity of the feeding baby which is going to harbor the bacteria. But this usually occurs in either in a very early phase where the mother has just started to breastfeed, it's a first time breastfeeding, so it could be accidental injuries. And second, when there are weaning off, when the teeth will start developing in the kid, and then there will be accidental injury to the nipple, and that injured nipple itself will harbor as the source, and that source will cause retrograde infections. Okay? So oral cavity of the feeding baby or the baby itself, again, initial part of the feeding and then later when the weaning off period is occurring, that are the two important phases where the patient can develop breast abscess. If I say what is the most common organism, the most common organism causing breast abscess, it is going to be Staphylococcus aureus, that is your Staph aureus. That is going to be Staph aureus. Right. So these are the baseline data for your breast abscess. So how does a patient of breast abscess going to present to you? The clinical features of breast abscess. So when I say clinical feature of breast abscess, this is going to present to you as acute mastitis. So breast abscess will have features of acute mastitis. Now for me, now I know it is itis. Itis means inflammation. Inflammation will have what? Ruber-Calor dollar tumor. Same features will be present here also. So when I say the patient is now going to present to you with features which are persistent with acute mastitis. So acute mastitis, inflammation, Ruber-Calor dollar tumor. So what is going to have? So in this, the patient is going to have sudden severe. There will be sudden severe onset of breast pain. So in our language, we will not say breast pain, we will say mastalgia. Right? So there is sudden severe onset of breast pain, or also referred to as mastalgia. Right? So one, there is going to be pain. Along with pain, the patient will also develop fever. It usually initially starts with a low grade fever, but if it is left untreated, it will convert into high grade. So when the grade of the fever becomes higher or more, it indicates that the infection is becoming more and more severe form. So different phases that you have. Initially there is phase of inflammation, then there is phase of cellulitis, and then it forms into an abscess. Okay? So in the early phase, there will be a lot of pain, there will be fever, ignored, then it becomes into an abscess. So a sudden severe onset of breast pain, it is associated with fever, and when the patient lands up to you in the OPD. So sudden severe onset of breast pain is there, patient will have fever, and then obviously when you examine, so when the patient comes to you with these features, I would like to examine. On examination, number one, obviously inflamed breast will have redness. So there is redness over the breast. Now this redness over the breast, it is nothing but erythema. So it's an inflammation. This is, giving you a cardinal feature. So yes, there is an existent form of erythema is present. So this presence of redness over the breast is present, right? So you have the patient with the redness over the breast. Now you examine carefully. The patient won't let you touch the breast because it is extremely painful. So there is severe tenderness. There is severe tenderness. If you watch closely, because of inflammation, there will be subcutaneous edema also. And in our first class of the breast, or like say, I think in the clinical examination part of the breast, I told you a finding which is called as peau orange. That is orange peel-like appearance, which is seen in subcutaneous edema of the breast skin. So here, because of acute mastitis, the patient will also have peau orange. The patient will also have peau orange. So there is redness over the breast, the severe tenderness, acute mastitis will result in peau orange. Along with that, there will be presence of painful. There will be painful axillary lymphadenopathy. It is painful axillary. There is painful axillary lymphadenopathy. So there is redness, pain, peau orange, and painful lymphadenopathy. Obviously, it is a reactive lymphadenitis, which will resolve once the infective foci also resolves. Now, what is interesting is whenever there is any fluid-filled cavity or abscess in the body, we have something called as fluctuation sign positive. So to understand this, so any form or any fluid collection in body will have fluctuation sign positive. There are certain exceptions. We'll talk about it. Now, what is this fluctuation sign? Now imagine that this is a fluid filled cavity. This is a fluid filled cavity which is present here. So this is a cavity which is filled up with the fluid. So whenever you're doing a fluctuation test, there are two important rules to a fluctuation test. Number one, whatever I'm going to show you as you're performing the test, you have to do in two different directions perpendicular to each other. If you've done like this, then you have to do like this also, right? So two different directions perpendicular to each other, you have to perform this test. So what is this test, right? So you will take one finger and you will put one finger on one end of the swelling. You will take the other finger and you will put this finger on the other end of the swelling. As simple as that. Now once you have done this, now you will start to exert pressure from one finger, and this is what we called as the examining finger. The other one will be called as observing finger. Now if it is a solid lesion, you can see here, as you exert pressure, if you exert pressure in a solid, it will move. If it is mobile, it will move, otherwise it will remain fixed. But if it is a fluid filled cavity, when you exert pressure, as you exert pressure, you will displace the fluid, right? Now fluids, obviously they can deform. So now as you're exerting the pressure, you will now notice that this swelling is going to get deformed because the fluid that is available here is now going to shift because of the pressure that you're exerting. Now you will notice all the fluid that is present here is now going to move on to the other end, and this displacement of the fluid is because of the pressure that you're exerting with your finger. So your examining finger is here, right? And your observing finger has moved across here. So this examining finger is here, this is the observing finger, you have exerted the pressure. Now because of this, what is happening? This is moved up. So what has happened? Now you see here, right? You're seeing your examining finger, your observing finger, both are the same level. Here you see the examining finger is going down, the observing finger is going up, right? So as there is displacement, the fingers are moving up. So you're trying to press here, this goes up. All that you have to do is repeat now with observing finger. Now I'm going to exert pressure with the observing finger. Now if I exert pressure from the observing finger, you will see the fluid will displace again, but in a different direction. So as I'm exerting the pressure from the other end, you will now notice that the fluid is going to displace in the opposite direction. You see, as you exerted pressure here, all the fluid that is present here is now going to get displaced. It is now going to get displaced, and this displacement of the fluid is going to occur across here. So now you see the observing finger is now becoming the new examining finger, and the examining finger turns into your observing finger. It turns into your observing finger, right? So this was your examining finger, this was your observing finger, but now this becomes your examining, this becomes your observing, because you are exerting pressure from here, and this is going to move up. So what I'm trying to tell you is, whenever I say there's a fluctuation sign positive, the swelling gets deformed on exerting pressure, and this deformity of the swelling on exerting pressure tells you that is a positive fluctuation sign. The criteria is the same test if this is the swelling which is present. Now when this is quite important, that this test has to be done in two perpendicular direction. That means if this is the swelling I'm giving you in a 2D image, so the fluctuation test that we have conducted, in one particular direction. You have to do in both directions, and they should be perpendicular to each other. So the direction of the test that you're doing, they should be perpendicular. So this is the swelling. So you should perform this test. So you do this way and you do this way also. Take it. So you have to do in, so if this is swelling, if this is the swelling, you do it in this direction and you do it in this direction. This is called as two perpendicular directions perpendicular to each other is to be performed to confirm the fluctuation sign is positive. Clear? Now, what are the sites in the body where you will not find these fluctuation signs to be present, even there's a fluid collection? So, sites for delayed fluctuation sign. Sites for delayed fluctuation sign. That means even though there is fluid collection available, even though if there is a fluid collection available, you will have a delayed fluctuation sign. Even though the fluid collection is available, the fluctuation sign will not be seen in an earlier form. That is called a delayed fluctuation sign. So where would you see this delayed fluctuation sign, right? Now, let's say This is a representation of the patient. So I'll give you a small cartoon to remember this. So this is how the patient would look like, right? So what are the sites where you have delayed fluctuation sign? You remember this cartoon, it is more than enough, right? If you know this guy, he's a number one guy, he'll tell you all the important findings that we need to know for a delayed fluctuation sign. Okay? So what are the sites for the delayed fluctuation sign? Number one, if the abscess is present here, you will have delayed fluctuation sign, right? If the abscess is here, there is delayed fluctuation sign. If the abscess is here, there is delayed fluctuation sign. If the abscess is here, there's a delayed fluctuation sign. And if the abscess is here, there will be delayed fluctuation sign. Okay? As simple as that, right? Now, what are these sites, right? The first one is your parotid abscess. The first one that you see here is your parotid abscess. The second one is what we call it as pectoral, because it is seen on the pectoralis site, or simply can be remembered as breast abscess. So either you say pectoral abscess or the breast abscess, that is site number 2. The site number 3, it is your palmar abscess. Site number 3 is your palmar abscess. Then you have the perineal abscess. Then you have the site number 4, which is your perineal abscess. And the last one that you have is your plantar abscess. It is going to be the plantar abscess, right? So these are the different sites where you have a patient who will have an abscess, but there are delayed fluctuation sign. Fortunately, all of these will start with P: parotid abscess, pectoral abscess, palmar abscess, perineal abscess, and plantar abscess, right? Because all of them starts with P, it is very easy for to remember as these are the sites where you have delayed fluctuation sign positive. Okay? So we will not wait for fluctuation sign to arrive at these particular sites, right? So coming back to our breast abscess, right? So if a patient now presents to you with lactational mastitis or breast abscess, how would you like to evaluate? That is going to be investigation. So when you look at the investigations, how would you like to investigate? Right? So in looking at the investigation, remember the first investigation, as soon as the patient comes to you with the breast abscess, it is going to be the ultrasound of the breast. It is going to be the ultrasound of the breast, right? If I say what is the investigation of choice, the investigation of choice also remains as the ultrasound of the breast itself, right? So when you do an ultrasound, now the controversy, how would you like to manage? Would you like to go with only antibiotic, or would you like to go with incision and drainage with antibiotic? Would you like to do anything else and all that, blah blah blah? Now there's a very standard approach that we have for breast abscess. So I'll talk about the management of the breast abscess. So we'll talk about the clinical management of the breast abscess. Now here is an important thing, that any patient with breast abscess, no matter or anywhere in the body, if there's an abscess, if you don't drain it, no matter whatever antibiotic you give, it is not going to work. In fact, it will more cause consolidation and then result in what is called as antibioma, right? You don't want that to happen. You want to have a patient infection free. You want this foci to be out of the body. So when you talk about the management of the breast abscess, on the USG that we have done, so we will follow the ultrasound criteria. So when you have done the ultrasound, the first thing I will see the size and the quantity. The abscess that is collected, if it is less than 3 centimeters in maximum diameter, or I can say if it is less than 30 cc. If it is less than 30 cc in volume. In these patients, I would go ahead with USG guided aspiration. It is USG guided aspiration with antibiotics. It is USG guided aspiration with antibiotics, and then you do it sequentially, right? You ask the patient to come back after 1 week again, do it, and you do it for 2 to 3 times, and after that, if it resolves, it's good. Otherwise, start the patient on, or take the patient for next step. We'll talk about it. On the other hand, if the size is more than 3 centimeters in maximum diameter, that is the abscess cavity, or if it is more than 30 cc in volume, here you will do a negative suction drainage, with antibiotics. Now, what is this negative suction drainage is? You take this as the representation of the patient, and let's say the patient had developed the breast abscess. I'm just going to depict it at one particular site. Let's say if this is the breast of the patient. So that's for the keeping it precise with our normal, depiction. We'll keep it across here. Now, let's say that this is the breast of the patient that we have, right? And let's say the patient developed breast abscess, which is here, right? Now, this abscess, which is present here, this abscess, let's say, is more than 3 centimeters in diameter, or it is more than 30 volume or 30 cc in volume. So what we'll do is, we'll take this negative suction drain, which is what we call as a Romovac drain. I will insert the drain directly into the cavity. So there's a drain which is called as the Romovac drain. This Romovac drain will be connected to a negative suction canister. So this negative suction canister will be something like this. You'll see there is a component here, and these will be present like this. So you press this off, right? You press this, it creates a negative pressure, and under the influence of negative pressure, you will see all the secretions which are going to be present is going to trickle down from here, and it is going to be accumulated into this bag. Okay? So this is what we call it as a negative suction drain, and this drain which is popularly used, this is what we call it as the Romovac drain. So usually we connect it with a Romovac drain and allow it to drain and then give antibiotics. So this is how you can do it. But the criteria to put a negative suction drain, it should be more than 3 centimeters in diameter, and it should be more than 30 cc in volume, right? Now, even after doing this, if it reoccurs, let's say you have done both these methods based upon the criteria that was presented to us. If it fails or if it reoccurs, let's say it fails to resolve, or if it reoccurs, then you have to take the patient for incision and drainage. You have to take the patient for incision and drainage, and this incision and drainage obviously with antibiotic coverage, with antibiotics. Now, when we say what is the incision that we usually put here, remember it is going to be a radial incision. This is going to be a radial incision. Now, what is this radial incision is, if you take this as the representation of the breast, let's say this is the representation of the breast, this is the nipple area complex, and let's say this is the pectoralis fascia, just for the demarcation, right? Let's say the abscess in the breast is formed here, right? So how would be your incision line? Now, the incision line usually follows the line in which your Cooper's ligament are traveling. This is the line. So when you look at the Cooper's ligament, this is the orientation of the Cooper's ligament that will be present. So this orientation of the Cooper's ligament is what we call it as the radial arrangement. So whenever you have an incision, my incision will always be parallel to that of the Cooper's ligament, and this is what we call it as radial incision. Now, another reason why I've put radial incision is all the TDLUs that are present, that is terminal ductal lobular units, they will also have a radial arrangement. Now, because they have a radial arrangement, if you do not follow this radial principle, what is going to happen? You might damage more of these ducts, right? So TDLUs will also, they are projected in a radial fashion. So when you put an incision, no, I'm not saying that this is 100% proof. This can also cause a damage in the TDLU units, but then the probability of damaging in this is less. Imagine this pink lines are your TDLUs, and I plan to give an incision. Which is, let's say, and I'll use a different color so that it highlights. Let's say I plan to give an incision which is like this, right? The blue line is my incision. If I give an incision like this, what is going to happen? It is going to cut through major. See, you can see 1, 2, 3. 3 TDLUs are getting damaged, right? To minimize the TDLU damage, we'll go ahead with radial incision. See? So I hope everybody is clear with the algorithm. This again is going to be an important exam point. If you are a NEET PG aspirant, if you are an INI-CT or an FMG aspirant, this is how they ask you in the exam question. And whenever you're going for your clinics and you know exactly how to solve a question on a patient, or let's say the treatment protocol for a breast abscess, this is what you're supposed to follow. Is everybody clear on this? Quick feedback. So far, any questions? Anything that you want to ask? Quick feedbacks. Right? Chalo. If you have no questions, thank you so much for joining today in the BLS series. So this addresses the benign disorders. The next week when we start, we'll start with the breast cancer. Do tune in for the next episode of BLS. That will be next Monday, Tuesday, Wednesday, 9 to 10 p.m. In the next series of BLS, we are doing breast cancer. We talk about how do you classify, how do you diagnose it, what are the findings, what are the TNM classification, management protocols. All of them will be dealt next week. So Monday, Tuesday, Wednesday, do file in. We'll also cover small miscellaneous topics. For example, breast reconstructions, especially the oncoplastic reconstruction. There's something called as volume reduction, volume displacement oncoplasties. So all these interesting small concepts. So what is multifocal disease? What is a multicentric disease? So we'll try to sum it up together, right? So that you have a sound knowledge. Please do tune in next week for the BLS. We'll be talking about breast cancer exclusively. Until then, if you have any questions, any queries, you know where to find us. The Telegram and the Instagram is You're the Surgery Guy. It is by my name, that is your Dr. Sandeep Seeram Reddy. Right. Thank you so much for joining today. We'll see you next week. Again, the notes will be shared on the Telegram group. You have the entire set. Do watch the videos again. If you have any questions, any queries, any concepts that are not cleared, just pin us down. Thank you so much. Until then, good night. Take care. Have fun. Bye-bye.